very good morning to one and all. Welcome to the second day of the GDBPCON 2023, the Growth, Development and Behavioral Pediatrics Conference of IAP. We start the second day of the conference with the paper session. I now request the judges for the paper session to occupy the dais. We have three renowned judges to judge this most competitive paper: Professor Dr. S. Srinivasan, former Director Professor JIPMA, Professor Udaya Kumar, Professor of Pediatrics and Developmental Pediatrician Srihar, and Professor Dr. Meenakshi, Head of the Department Pediatrics, Isabels. May I request the judges to occupy the dais. So, instructions to the participants: you will have 8 minutes for presentation, and 2 minutes the judges will be questioning you. The question should be only from the first author on the podium. The questions will be answered only by the first author on the podium, and the questions will be only from the judges and not from the floor. Kindly ensure that you don't exceed your time, because exceeding time entails negative marking. Kindly adhere to the timings and the format in the presentation. And please ensure that you also maintain anonymity throughout your presentation, which might also invite negative marks. So, without much further ado, we'll proceed with the paper session. The first paper, may now request Dr. Shritama Chowdhury for her paper on effectiveness of a culturally appropriate model group and individual therapy in children with ASD. Over to Dr. Shritama Chowdhury.
So good morning everyone, and my deepest regards to the revered judges on the dais. Today I'm going to be presenting our paper on the effectiveness of a culturally appropriate model group and individual therapy in children with autism spectrum disorder. So as we all know, it is a pervasive neurodevelopmental condition which is characterized by impairment in social interaction, communication, and repetitive and stereotypic patterns of interests and behaviors. There are a multitude of causes, and the presentations are largely heterogeneous in nature, but the most of the intervention models are based largely on Western data, which are oftentimes not suited to the Indian context. So the aim of our study was to evaluate the effectiveness of a locally developed, socio-culturally appropriate intervention model which targeted the core symptoms of autism. The first objective was to provide the intervention package to the children aged 2 to 6 years diagnosed with autism spectrum disorder using the DSM-5 criteria over a period of 3 to 12 months, and to evaluate the said effectiveness of the intervention in changing the core symptoms through the pre-post comparison of Trivandrum Autism Behavioral Checklist. This was a hospital-based pre-post quasi-interventional study conducted in our neurodevelopmental clinic over a duration of 12 months. We included consecutive children diagnosed with ASD whose parents consented to the study. We excluded children with a comorbid diagnosis of global developmental delay and children taking medications for comorbidities. The materials used was DSM-5 criteria for autism and Trivandrum Autism Behavioral Checklist. This checklist is a parent and clinician rated chart with a 4-point Likert scale divided into 4 principal domains, that is social interaction, communication, behavioral characteristics, and sensory integration, and it has been validated against scars with a very high negative predictive value. Based on this, we divide the children into 3 subgroups: non-autistic, mild to moderate autistic, and severely autistic. The intervention package was developed based on the principles of applied behavioral analysis and developmental social pragmatic model. Based on the principle of Vygotsky's socio-cultural theory, we utilized the parents as the principal therapist who were only scaffolded by the professionals. So even though the therapy was taught in the institution, it was largely home-based in nature. The components included a group intervention package which was delivered in a peer group setting, an individual intervention package which was individualized based on the profile of the individual child, that was analyzed by a SWOG analysis by the developmental pediatrician and then delivered by a developmental therapist. The package also included home-based therapy through parental training and counseling. The individual therapy was based on the principles of ABA like motivation, shaping, chaining, task analysis, differential reinforcement, and verbal behavior, and it encouraged imitation, eye contact, attention, communication, sitting tolerance, and self-regulation. The group therapy composed of the following steps. It was largely based on Albert Bandura's theory of social learning on the principle that children are mostly observational learners, and it mostly encouraged communication and socialization between the children. This is some of the pictures of the group therapy being practiced in this setting. The intervention period was over 3 to 12 months. At the very onset, ethical clearance was taken from the Institutional Ethics Committee and informed consent from the parents. Outcome measurement was changes in TABC score. Statistical analysis was done on the SPSS software, and since the distribution of samples was parametric in nature, one sample paired t-test was used to compare. So this is a standard operating procedure that we followed. At the very onset, after the diagnosis was done, a SWOG analysis was done by the developmental pediatrician and planning of therapy by the transdisciplinary team. After taking consent from the parents, the children were introduced into the package and given the intervention. And after a fixed intervention duration of every 3 months, every child was individually reassessed by a developmental pediatrician who was blinded and independent. Thereafter, we did the statistical analysis. We included 82 children in our samples, of which 41.5% belonged to the age group of 36 to 47 months, and a majority, that is 85.4% of the sample, were male. Okay. So majority of the children followed one session per week, that we group or individual therapy based on the convenience of the parents, while others followed one individual or one group therapy per week. Duration of sessions were ranging from 3 to 12 months. Majority were attending the session for 3 to 6 months. This is the pre-post comparison of the scores. After the intervention period, we found that 25.6% of the children did not meet criteria for autism anymore as per TABC, and from a 47.6% in the severely autistic category, they had come down to 20%. When we looked at the subdomain analysis, we found a statistically significant improvement in total score, socialization, communication, behavior, and sensory integration domain. And individual items showed improvement in maintaining eye contact, name call response, tasks involving social understanding, gestures for demands, initiation of pretend play. Inappropriate attachment to objects was reduced, reduction of hyper and hypoactivity, reduction of sensory modulation problems, and sensory craving behavior. So the summary and discussion is that this is a very simple, culturally appropriate model, which is mostly parent delivered, therapist guided. It does not require a prolonged, time expensive training on Western intervention methods, but it can be utilized by community workers all over India. And the findings are quite similar to other parent-mediated interventions which are practiced in India, as seen in papers by CDC Kerala and CMC Vellore. We did not find a significant improvement in echolalia and motor stereotypies in our study, but currently echolalia is being considered as a stage of normal acquisition of language in ASD. So the management is quite controversial in this setting. Sensory integration and modulation problems are mostly targeted in occupational therapy sessions. So we could not analyze the confounding effect of that in our study. And also we did not control for the confounding effect of developmental age, cognitive and adaptive functioning in the study, which we are trying to do in our next study. The limitations of this study was we could not have a control group. The sample population was largely heterogeneous in terms of comorbidities and etiology. So ideally a etiology or comorbidity wide analysis should be done. And some of the children, even though the percentage were very low, they were receiving some complementary and alternative medications and occupational and speech therapy. Thereafter, the confounding effect of these treatments on the core symptoms cannot exactly be ruled out. With this, I would like to end my presentation. Thank you so much for your kind attention.
So that was a nice and relevant presentation. And what do you think is the limitations in the study, apart from what you have put up?
Sir, actually, the analysis has been done only using TABC, and TABC has some pre-post test variability. It has some individual rate of variation as well. We try to minimize that as much as possible by utilizing one particular developmental pediatrician for the pre-analysis and a separate one for the post.
Do you think age would have been a factor in terms of, say, response to treatment? Have you categorized your this thing, because 34% of children are less than 3 years. So do you feel the results in that group have you done any subgroup analysis?
I couldn't hear your question.
Age less than 3 years and more
Yes.
than 3 years, it can make a difference in terms of, say, response to
Yes,
intervention.
sir, definitely. Actually, sir, the best response we are seeing when we start the diagnosis early, around 18 months of age, and we start intervention early. So, in the 1.5 to 3 years age group, we find the most improvement. But we have not categorized them separately in this paper.
Okay.
We plan to do it in our
Okay.
later study.
So, what is the treatment period of the parents in terms of, say, trying to get used to the intervention?
Sir, the parents required at least a 1 month period to first accept the diagnosis and accept that the child needs therapy. So, for the 1 month period, our most focus is on counseling the parents about accepting
Training period for the parents, how long
it is
it took?
intervening, sir. For every therapy session, parents are always with the children. So, for every session, the developmental therapist sees the child, gives the intervention and gives parents certain homework, which is notified in the copy, so that they can go home and practice. And next session, it is again reviewed, how much they have done, how much the child has been able to comply with them.
Okay, so what is the difference between NDBI model and ABA therapy?
Sir, ABA
And how
therapy,
you went about with the group ABA therapy?
Sir, ABA therapy is technically based on only principles of behavioral analysis. NDBI utilizes the naturalistic development of the child, where only what responses the child is initiating, that is reinforced by the parents, and through the normal developmental process we try to create changes.
So how you did the group ABA therapy?
Group ABA therapy. Sir, in our paper, sir, it's not group ABA, sir. We have only taken the principles of ABA, but it is a very naturalistic, developmental, social, pragmatic model, sir. Only principles of ABA has been used.
Yeah, I just want to say, of course, you started, I am presenting a paper. It's a study, not paper. Probably
Yes,
it
sir.
is not yet published.
Yes, sir.
So that's the only thing. Otherwise, I appreciated your body language, the way you were talking confidently and
Thank you,
facing the, this thing. So that's very good, important for getting this thing. And of course, he has asked the most relevant questions. So I will not ask any questions. So I am satisfied with the way he has asked and he has answered. Thank you.
Thank you.
Presentation was good.
Thank you, ma'am.
Yeah.
Thank you, judges, and thank you, Dr. Sritama. A note to the participants, you have already been assessed on the basis of the originality of your paper, the applicability and reproducibility, study design and method, statistical analysis, observation tables, and discussion and message. Today, on the external evaluation, you will be evaluated on the basis of the relevance of the study, the methods, the statistical analysis, validity of the conclusion, and the time taken for the presentation per se, and the discussion and answers to the questions.